let's get the party started. I want to introduce my fellow colleagues here and our special guests today. I'm your host, Dr. Desmond Bell. Welcome to Inside the Doctor's Lounge. It's a place where we can all come together and have some honest discussions about a myriad of topics. We never know where the discussion's going to go, just like what happens inside a real doctor's lounge. It's a place where you can have honest conversation and just be yourself and not have to worry about who's listening or any repercussions, although we want people to listen and really stimulate some thinking in this. So with that, I'd like to introduce my colleagues, the CEO and founder of MD Coaches, Rhonda Cook, Dr. Dael Waxman, Dr. Randy Cook, Dr. Rick Zollinger, and our special guest today, who is not a physician, but he comes from a family that is well entrenched in the medical field. His dad was an OBGYN up in the great state of Georgia. And I say up because I'm down in Florida. But anyway, Carl Schuessler, welcome aboard. And
Thank you.
You know, you're welcome. And so we're going to get this topic started today.
Hey, Des, I just want to interrupt you a second.
Did
you know that Rhonda got married this week?
No, where's the punchline?
You introduced her as Rhonda Cook.
No, I did.
Yes, you did. But remember, believe in me, see me, do all that stuff.
It's all good. I'm rolling with it.
Right. You know, because Carl keeps saying Dr. Cook, Dr. Cook, Dr. I guess Cook just stuck in my head.
All right.
Congratulations, Rhonda.
Just call him Randy, for crying out loud. You're amongst friends.
Yeah.
Sorry, Rhonda.
Sorry, I didn't mean to interrupt.
No worries. I'm rolling.
It's probably the closest I've come to blushing on this show now. I can feel like my ears are getting all red and
We're going to have to bring my sister wife, Jennifer, on though. So
good reply. Good reply. Well, listen, you know, so Carl, you already got a taste of what goes on here. You know, there's going to be little mess ups here and there. That's part of the fun. But who knows where our conversation is going to go today. But we wanted to, because of your expertise, as really, let's call it a risk management specialist in a sense. You know, your background, you chose not to take the path of medicine directly like we all did, but you're still in the medical community and have been all along, but you're just on the other side of it. You're more on the business side than on the insurance part of it. But I think, you know, I'm probably not doing any justice exactly what you do, but we'll get into that. You know, with that, in previous discussions that we've had here inside the lounge, there's been an undercurrent of the shared sentiment of our frustration in all of our years in practice, the obstacles that we have encountered in trying to do the right thing for our patients. And a lot of times, the biggest obstacles that we run into are insurance coverage. We see either uninsured patients or working poor. And at the end of the day, so much of our energy is spent fighting insurance companies, trying to do the best thing for our patients, and truly being patient advocates. We all went into medicine, I think, because we had this calling, and we felt this connection with our fellow human beings, our patients, our friends, our neighbors, and so we wanted to make the world a better place in our little way. So, you know, from your perspective, you know, I know you've shared some of the frustration, and I heard your story about catching a baseball in the face a number of years back, ending up in the emergency department, and really kind of, I don't know if that was one of the defining moments, but it certainly had an impact in you in realizing at that moment how, as a patient, you don't really have much say in the cost of services. You don't have the ability really to shop around, especially in an emergency situation, and so on. So, you know, with that, we all have been frustrated. And I want to start off today's topic talking about this, and really from also a perspective, though, of a topic or a term called direct primary care. And where does this take us in you know, really the big picture in healthcare today? So I'm going to turn it over to you, and I'm sure we're not going to have any problems getting started. We may have a hard time getting a word in edgewise, but we'll gong you at the appropriate time.
Well, now, what did Dr. Cook tell you guys? I mean, golly, getting a word in edgewise. That's just
They heard the podcast, my friend.
Okay. Well, I got a little jacked up. I had too much Mountain Dew that day. No, direct primary care. I think I've been very blessed in kind of this journey that I've been around. I'm going to leave many names off, but really my first exposure to it was probably Dr. Shane Purcell out of Anderson, South Carolina, where I really was getting to know someone that was direct primary care.
Let me even before you get into all that, why don't you just tell us a little bit more for people who haven't heard of direct primary care? Tell us a little bit more about the concept, exactly what it is, and then you can do your acceptance speech and thank everybody. And you know, we're going to give you the business today. No, in all seriousness, please go ahead.
Dr. Bell, I don't know what to do here. I mean, I just, yeah, direct primary care. I've done this a lot when I've done these talks, and I was doing it with those doctors in Northern Michigan. Most of them knew what it was, but for the audience and people that don't, I say it's kind of like going back to the Marcus Welby MD days. And unfortunately or fortunately on this show here, I don't think anyone has to Google Marcus Welby MD. I think they'll know who it is, but normally I've got all these millennials and they don't. I say go to YouTube and look it up, but I was supposed to be funny, apparently not. But anyway,
we got it.
We got it.
I know, but nobody laughed. I mean, you're a pretty funny guy.
It's hard to get a laugh out of those kids.
Okay.
Yeah, that's for sure.
But back in the day when I grew up, you know, you and my father's dad was a general practitioner in Columbus, got paid with milk and meat and stuff back in the day, Columbus, Georgia. The doctor, you had a relationship with your doctor. You knew who they were. You could sit down and talk to them. You saw them in the community. You were just involved, and it was a totally different feel, and it was a real one-on-one relationship.
Absolutely.
And I know everybody knows here, so you just tell me if I'm going off track. But you know, in the late 70s, early 80s, or really, I'm sorry, the mid to late 80s, when managed care entered, you know, I'll never forget, and I think I shared that on y'all's podcast. You know, my doctor, my choice is a bumper sticker my mom had, and when the whole networks entered and everybody's in the network, that basically took the personal relationship out. And y'all heard that story about my dad, had a patient for 25 years, and they came in and said, "Hey, Dr. Seuss, I can't come to you anymore." And he goes, "Did I do something wrong?" And she said, "No, you're not in my network, and I can go over here for $5, and I don't have to pay, you know, what y'all charged here." And my dad just, he wasn't going to do networks, and he was blown away. And he came home, I'll never forget, he said, "It's over. It's all done." And he was correct. So I think the copays, the managed care obscured that relationship. It took it away. And now people don't have a relationship, and the physicians are all in this fee for service environment. So they got to see 4,000 patients a day to pay their overhead and cover all their insurance billing clerks, 20 of them in the office or whatever, dealing with all these awful insurance people.
You know, you brought up some important points, and you know, these guys are obviously a lot older than me, but that was a joke too.
That was a joke.
But you know, I think back to my, you know, about the first couple of years when I was in school, in podiatry school, and I remember, you know, HMOs were really just starting to emerge, and this was up in Philadelphia where I did my training and schooling. And at the time they said, you know, I remember around year number 2, they said, you know, you guys ought to look at HMOs, maybe join them, and it'd be a nice thing to do starting out. You know, you have some, you know, income automatically out of the chute, and so on and so forth. Well, by the 4th year, there was a panic had set in, and there was this real fear amongst people being blocked out of programs. And you know, it went from, hey guys, it'd be a great option starting out as a young practitioner, to, if you're not on an HMO, you have no chance of making it. And it really was a wake-up call. But then with that, the frustration, and over the years, I've certainly seen it, what your dad described, having patients literally crying hey, it's like, Dr. Bell, I'm sorry, I can't come to you anymore. My insurance company, and people a lot of times almost felt hoodwinked, like they were led down the garden path by external salespeople, let's say, who sold them a bill of goods. And then, you try and have to talk these people off the ledge in a sense and try and comfort them and give them some guidance. But anyway, I didn't mean to, already we're getting off track, but I think we all can relate. We all have our own stories. I just wanted to add that.
Well,
No,
I just was going to say one thing, because Dael has been, we were all surgical specialties and Dael was medical. And he's been there through the transition from the 90s to today. And wouldn't you feel, Dael, that, yeah, we've gone through this whole, and now I feel like we're backing the truck up to, in some ways, back to 1990. Guys are saying, yeah, I mean, all the young people are joining groups, and then you've got this group of folks that are going back and doing concierge care and going back out and doing direct care and saying, I'm happier this way.
Sure.
So I don't know. I mean, you're the one who has the greatest experience with the medical practice that way compared to all of us.
Yeah, well, we didn't get to hear Carl yet say what direct primary care is, but I did get the.
Hey, I can't get a word edgewise.
We prepared ourselves. No, I will say, so since we're talking about managed care, actually, it's all I've ever known. I didn't know Marcus Welby, although it was an influence on what choosing family medicine. But when I started residency in '85. And I started in the University of Arizona, and right before I got there, they had just done a managed Medicaid program, and so I learned very quickly about gatekeeper stuff, and that was the model, the gatekeeper HMO. There are some advantages from a primary care point of view. I'm going to say that there are some advantages to it. Carl has identified a lot of the disadvantages. There's a lot of challenges with it, but some of the advantages from a primary care perspective, back then it was a capitated system. I will say that I, as the primary care doc, knew everything that was going on with my patients, and the burden was I had to approve everything. I had to. Like if the surgeon saw my patient and said, well, you don't need me, you need to go see the gastroenterologist, it had to come back to me first. And so that was not good for the patient necessarily, but it was good for the primary care doc to know what was going on and sort of controlling the flow of where things were going. But it was a burden. How, on the other hand, the positive was I knew everything was going on with the patient. I knew everywhere they went. I knew, we had a formulary. There was a lot of positives to it. There are a lot of negatives to it, but there were a lot of positives from a primary care point of view. Over the years, I will just say that we definitely have gotten to that place. And I'm teeing you up, Carl, for a description of direct primary care, because I've been involved in education all these years. I've been we're wanting to talk about low income or people with low resources. It's gotten more and more and more complex, as we all know. And it's not just managed care, it's all these other layers and layers and layers that have really driven a wedge between the physician and the patient. These layers of quality measure, all of them well-intentioned, but and so I have graduates who are entering direct primary care because they went into it for the personal relationship with their patient. So now, Carl, you can describe what direct primary care is.
So Dael, it was a tease. We were trying to hold off on giving the full definition until the end of the show. Go ahead.
Well,
Go ahead,
before Carl, if you don't mind, I just want to add my one little personal observation as well. This shouldn't take more than about 90 seconds. But back in the mid 80s, I was part of a multi-specialty group in Clearwater, Florida. We actually founded the very first HMO to exist in the Tampa Bay area. And the partners had to put in a really modest capital investment. And to shorten the story, we operated that thing for, I think, 3 years The patients were gloriously happy. They knew their physician. It was the same one every time, the sort of the sort of thing that we're talking about. But after about 3 years, we were so successful that an insurance company came along and bought us and literally made us an offer that we simply could not refuse. And when it became a product of the insurance company rather than a product of the doctors, everything changed. So with that, I'm going to let you fill us in on exactly how this thing works.
I don't know. It's hard to compete with a bunch of physicians. Y'all know so much more than I do, and you taking care of patients. And I mean that. I think the biggest issue, and I'm going to give the definition. I mean, again, and I will be honest with y'all. One thing that drives me freaking crazy is a guy, like I was at this free to care conference that y'all may or may not ever heard of out in Austin a week or two ago. And everyone got up there, and there were a lot of doctors there, and they all yapped about all the problems in the healthcare. And I'm sitting here going, I finally just stood up and said, come on, we've known this for 7 years. Are y'all wanting to show how smart you are? I mean, come on. What about the solutions? What do we do to fix it? So I get very frustrated with that narrative, and I apologize. Y'all probably didn't know I'm a kind of passionate person since you did listen to the podcast. But you can't, I mean, when you look at a direct primary care doctor, okay, they have a one-on-one relationship with the patient. Some of them may charge $65 for an adult per month. So a husband and wife's $130, $25 for a kid. And a lot of them treat kids age 5 and older. Some will deal with youngers. And then $10 for each kid thereafter. That's certainly where Dr. Gross's prices are. We'll talk about in a minute. So with that, you get unfettered access to that physician all the time, 24/7. And you really have a relationship where they can spend time with you. The direct primary care doctor only will generally accept between 400 to 600 patients on their panel. And a fee-for-service doctor in the world today, and Dr. Waxman, you brought up some interesting points that you were really involved with the patients. I don't know what your patient panel was, but you go in these offices, they have thousands of patients, and therefore they can spend no time with you. The person I saw, and I'll leave the hospital off because my daughter works there now. Oops, I gave that one away. But they have a physician there, and that I saw some, and I mean, it was all about, it was literally like this, so Carl, how you doing? Well, I'm doing horrible. I'm about to die, I think. Okay, great. All right, good. I mean, you can't listen to somebody typing medical records in. And that whole system is terrible. My dad, before he retired, he aced the medical record system, but he said, this is a joke. It's only a place. It's only there so lawyers can sue us. That's what my dad believed.
That's a whole nother topic. And
but
yeah.
It's like Rhonda and I having a call, or if I'm talking to y'all and I'm on the computer, there is no way you can multitask. I'm sorry. There just isn't with 100% attention. Talk to your wife or your spouse and you're on your phone. You can't. So anyway, forget that. But my point is there's thousands of patients in a fee-for-service GP or internist. There is no way they can spend time. So instead of diagnosing situations, what we've seen is they refer to specialists. And I think it comes case in point when I was with Glenn Price, the CFO at the Gas Berlin Hotel, some of y'all heard about, know about. And by the way, get the new Physician Outlook magazine. I want to thank Dr. Wu Smith and her team, Dr. Bruce, and all the stuff they did. They dedicated the whole issue to mitigate partners in our event at Gasparilla. So I'm honored, and we're honored, and you'll see it, and it's all in there, and I encourage you to look at it if you haven't had enough of this today. But long story short, Glenn used to see Dr. Gross when Dr. Gross was a fee-for-service doctor. When I told him that DeSoto Memorial, a hospital, was putting in direct primary care and they own doctors, everybody misses that. Why would a hospital put in DPC? I mean, what? So when we did that, I was telling Glenn about it. Glenn goes, y'all are using Dr. Gross? I quit going in because every time I saw him, he referred me to a specialist. Well, since Glenn hadn't seen Dr. Gross in a long time, Dr. Gross changed his business model, as y'all know, and he was kind of one of the few early pioneers in the DPC and the DC and everything legislatively. And that was my point. I told Dr. Gross that story. And so we're all together back in June at that event that the Physician Outlook magazine's about. So I think when you look at it, I mean, I'm just telling you from a personal experience and what I've seen, there is no relationship. There is nothing there because you're trying to manage. It's like me trying to have 100 clients. It's not possible to do it the way we do it. So my approach is very similar to a DPC in my business. I don't want a lot of clients. I want good clients that pay me fairly and that I can give good service to, that I can take care of and make a difference for their members. So I think DPC, if I'm answering, I hope I answered your question. It's the one-on-one relationship to me that is extremely different than when you work with a doctor who's on in an insurance company network in a fee-for-service environment. It's night and day. It's not even close.
Well, Dael, you can speak to this too. The impression I have, and this, Carl, is as I interact. In fact, I'm seeing my family physician today, and if you call the office and they say, "Well, if you're really sick, call 911," and then you go to the ER and you're there with 1,000 people with the flu and whatever, and you can't get there. And the way I used to tell friends to orchestrate, if you have to go to the hospital, then call the brain surgeon. He'll get you direct admitted to the floor and say, "Call Dael." And that's how you do it. That's how you circumvent the ER. And so that's where the subspecialists came in over the last decade. That's the way to get in the hospital, because your doctor's office, you went to your family practice or your internist and they go, "Well, you're really sick. You got to go to the hospital." But I don't cross over there anymore. I don't go there. What is that place? They're right up there with plastic surgeons, who never go to the hospital anymore. You can't see a plastic surgeon in an emergency room. So that's the thing I have. That's why I'm interested in what Dael's perspective is, because that's the person that as I grow older, I'm most interested in. So how is he going to deal with me as a patient going forward? So
over the course of the past couple of years, we've had this common theme a lot of times where how did we get to this point where so many physicians are burning out and just disenchanted with medicine in general? And we've just touched on some of this. It's that workflow, the overwhelming, patient demands that are placed on you by the insurance company in the way the model is now. And then to take it even a step further, the EMR aspect of it too, where you are multitasking and the laying on of hands has been diminished. The ability to interview a patient, look them in the eye, has kind of gone by the wayside in many practices. So I think what we're seeing here too, but with DPC, is this ability to kind of help us get back to our first calling and the roots of medicine, which is taking care of the patient, not fulfilling quotas or needs that are put on us.
Well, let me say one thing on that, Dr. Bell. What was really interesting when COVID hit is that really showed all the fallacies in the healthcare system. Everybody here agree? Okay.
Yeah.
And my wife and I, it was almost a year ago, actually probably about this time, I had some speaking engagements in Kentucky and Indiana. I don't know if I got sick. I started up there. I don't know if it was from there or from my daughter who tested negative for COVID, but we're pretty sure she had it. So Missy and I both had it in October last year. And Missy was about 2 days later than me, and she was feeling terrible. So I had to drive through the drive-through testing thing, and her heart rate was like at 119. And the nurse said, "You need to get to the ER and go see your doctor." Her doctor literally, even in Atlanta where we are, happened to be right around the corner. So we drove over there, and they wouldn't see her. They wouldn't see her because she hadn't gotten a test result back from COVID, so she couldn't see her doctor. So we came home, and she had a horrible sore throat. It was terrible, and her symptoms were very different than mine. We called Dr. Gross down in Northport, Florida, and obviously he's not our doctor. He's a friend, and he talked to her and said, "Miss, you have any heart problems?" She said, "No." She said, "More than likely you're fighting an infection, and you might want to get some prednisone or something, or maybe a steroid or some type or something." I think that's right. I don't want to misquote him or make him sound bad. That's what I recall, something like that. But he spent 5 minutes with us, And he still saw patients all through COVID. So the DPC practices went through the roof because they were still seeing patients. And that's kind of what I'm saying. I mean, you know, telemedicine, you know, obviously was really garbage up to that point because we put it in our plans, and I watched the utilization of that was not good. Now, obviously, it's off the chain, and everybody has it.
Yeah.
Doctors' offices are offering it.
One of the silver linings that emerged from COVID, what was the emergence of or moving telemedicine up to the front of the line. I mean, we needed it in wound care forever, and now it's being utilized. But anyway, please continue.
But I just want to say that's the difference. And I mean, when I say a relationship, I'm talking about a real relationship. When you're one of 2,000, there's no relationship there. There's not. And I've watched it. I've watched a person that was on Percocet for 15 years. I watched Dr. Gross bring in the spouse and sit and consult with them both, fire their pain doctor, and the person is now opioid free. I didn't even know you could walk and talk on Percocet. But,
yeah.
you know what I'm saying? That is the difference. There's no way a primary care doctor in a fee-for-service environment could ever do that and follow up to make sure you came back. So it is not even close. I need to get a DPC doc. We have one in Vinings. I'm embarrassed to sit here and tell everybody that I don't have one. I'm sitting here running my mouth about it. You know, so we need to get one. And I met him at Dr. Gross's conference in 2019.
So, you know, and hearing this too, and I agree, we're all problem solvers, and it doesn't really do much good to just continue to gripe about a problem unless there is a solution that you can come up with or follow. But I think what DPC model really provides or offers is a solution for both patient and the providers and the docs alike. We're frustrated, patients are frustrated. So how do we get, you know, tell us a little bit about some of the trends in DPC. You know, I would think that the model is now working, and we're seeing more practices adopting this model. But how do people, you know, let's say if you're a physician and you want to join a group that is part of this concept, or a patient, how do you find these particular docs? Because, you know, it's one thing to hear about it, but how do you go about, you know, implementing this at both levels?
Yeah, that's a good question, Dr. Bell. I would say that the biggest challenge that you have with the DPC model is you have doctors that are hybrids, take Medicare, might take some insurance, and are trying to start their DPC practice. That's subscription-based model. Obviously, you can do the math, 65 times 600 people or whatever, and you can kind of figure out how it works. The challenge is you've got to get someone that stops cold turkey and can go right out and start a subscription-based model. The next challenge is most employers in America are small. They're small companies. So Dr. Gross and many of these people, with exception, and this is Shane, by the way, Shane Purcell's book. If y'all haven't seen it, you ought to get it. Magic, Pixie Dust, and Miracles. Unfortunately, he's got a little comment by me in the front, but other than that, the book's great. But anyway, that was supposed to be funny, but I'm trying to look at the camera, not look at y'all's face. But Christy Gupton, one of our Mitigate partners, helped in a lot of aspects. Christy's one of the most foregone experts on direct primary care there is, but she's a benefits advisor in North Carolina with us. But that's a challenge in itself. And when they run out in the marketplace and there are groups of 5 and 10 employees, those are easy groups to get. But when you get them in your practice, Dr. Bell, just having DPC is not going to cut it. You have to have some type of catastrophic insurance with it. And so that gave birth to the medical cost sharing ministry programs, Sedera, which is a sharing program, but it's not religion specific. Tony Dael is a wonderful man. Y'all might know a physician that started it. He wrote a book also. This book, if y'all hadn't seen it, it's pretty good. Tony Dael, The Cure for Healthcare. He's out in Austin, Texas, and he started Sedera. And so you've got to marry that DPC with some catastrophic plans. And then the problems then become for the members is if they got any pre-existing conditions and any issues, they can't get the Sedera plan. So it's gotten a little convoluted, but they have focused and been able to win on these smaller employers. But Dr. Purcell was different in that he got Anderson County, South Carolina, right outside of that other orange school, Clemson, which I actually don't mind Clemson. I like that, but I don't mind Clemson, even though we took them down this year. Of course, it looks like everybody's going to take them down now. But anyway, Dr. Purcell got Anderson County, and there are about 600 some employees. So he had to onboard all that. So there he is getting a full panel like that. So when you look at the I don't know if I'm answering. When you look at the challenges of it, then you got a company that's, you know, got a few employees down there with Randy in Alabama, got 100 in Atlanta, 200 in Tampa, 5 in Cincinnati. That gets very difficult to do because that doctor up there charges $100 a patient. This one charges $65 a patient. How in the heck do you do all that and make it work? So we're working on some things. I can't say much about it to try to make that more uniform, but I gave Rhonda, I think, these links. I think I did, Rhonda. I give them to people all the time, the DPC Mapper and DPC Frontier. Those show where most of the DPC docs are, but it is challenging. We got a group down on the Southwest Gulf Coast, not far from Gasparilla, that we're trying to help. And the doctor we want is full. And we got about 82 people we can send them, but we need to get another group. And that group decided not to do anything at this moment. So we couldn't give them a full panel to hire another doctor. So those are the challenges that I think you're going to see around the country. And then the other challenge is if a DPC practice takes on a big group and that group decides, we don't want to use DPC anymore, then they've taken down bricks and mortar and they're left holding the bag. So it's a real difficult thing. And you've got to find, and when I'm talking, the reason I brought up numbers of employers and sizes, if you're going to bring a doc on and get them to stop taking Medicare and insurance, they got to be able to build a panel. And then the next thing they have to do is they got to get into communities. And no offense to any of you guys on this phone call. And the only one I spent more time was Randy. And I think Randy could sell anything. He's just got the most soothing voice in the world. I mean, the best voice there is that I've heard. But most of these doctors are not salespeople. But they're respected in their communities. And I gave this talk at Dr. Gross's 2019 DPC Nuts and Bolts, about 400 DPC docs there, about how to acquire clients. I did that talk with the physicians in Michigan. That was part of my talk, how they could do it. They have to go out in the communities and do direct contracting with these employers. And I don't know if I'm getting way off base here. That's what they have to do. They've never done that. And all their patients before in their old life was through the network. Like you said, they got blue. It's all focused on what we call the processor. Don't you ever use the word payer. They're not payers, they're processors. The only payers in healthcare are employers and employees. And Medicare and Medicaid, the only payer is the taxpayer.
Carl,
Amen, brother.
Let me ask you a question. This just came into my head. So,
hey, I was on the roll, man. You're interrupting.
No, I know. Shit. I'm sorry. Oh, excuse me.
Go ahead.
Oh, well, they can bleep that. They can bleep that. What the heck? Sorry. No.
Go ahead, Dr. Zollinger.
What I was going to say was, I was thinking about corporate Lowe's, for example, in Charlotte, and what they do with their cardiac care, routine cardiac care, they ship to the Cleveland Clinic. They take care of the airfare and everything for their employees of corporate Lowe's. So in that setting of a large employer, why can't you take this model and have it on site? And I don't know how many people they have on site. They may have 3,000 corporate employees. So you hire that many physicians and then they have a core group and it's just within a business. Why wouldn't major businesses do it that way?
That's a great question, Dr. Zollinger, and some of them are. They're calling them on-site clinics. That's been kind of going on for 25 years or so, okay. 30 years.
Yeah.
So that is out there, but you just said it. You have to have enough people in that one location to have it. And if you've got them spread out in 20 cities, you can't put one in every city.
Right.
A clinic or a medical home is what I would prefer to call it, or a health center. The school district we used to work with, I don't work with anymore. One of my partners, Barry Murphy, works with. They have a health center right there, and it serves that whole county school district, about 9,100 and belly buttons, 6,500 employees, and it serves it, and it does a good job. But they need multiple locations. It's a big county, and I agree with you 100% on that works. And medical tourism works. Dr. Gross set up a knee replacement at DeSoto Memorial Hospital in Arcadia, Florida. He set one up, had a surgeon come in from Sarasota to do the surgery. That's about an hour drive. So the surgeon came in and they did it for $17,000, which is unbelievable. And that put money back in Arcadia and at DeSoto and keeping it local on Main Street, not on Wall Street. The way to fix this thing is you've got to get the money off Wall Street to Main Street, period. You eliminate the middles, and that's what DPC does. And when you build these plans, these employer-built plans y'all heard me talk about, that's when you get rid of it. You got to get rid of these insurance companies. They're not in the healthcare business. They're in the money-making business. They don't know anything about it.
I've tried to explain that to my patients over the years. I said, listen, the insurance company exists not to take care of you. They are there to make a profit for their shareholders. Understand that. And you throw that out to them and they start to get it. But so here's something though that, as we're talking about this, and DPC model it's really, to me, a response, find a need and fill it. There's obviously been a need, and that has spurred this, how this was born, regardless. But now I'm looking down the road, and I love the concept, and I think it could fill a major need. But as we start to move towards a single payer healthcare system, what would happen in your estimation? How does this all pan out? Do you see us going to a single payer? If we do, does this survive?
I've got good foresight, Dr. Bell, and I don't know if I'm also a fortune teller, and I can tell your future. I left the crystal ball.
Sort of like Karnak, I get it.
I left. I didn't know if Dr. Cook told you that or not, but we did that. He probably didn't share that with y'all because I pulled the crystal ball and was talking about what's going to happen to him the next day. But Dr. Bell, I'm gonna be straight with you, man. I'm not smart enough to know that. I'm just not. I look ahead. I don't know. All I know is that my mission, and everybody knows this, I'm extremely mission oriented, is to change this thing one employer at a time and bring these other mitigate partners together to try to teach them and mentor them, the ones that need it, to do the same thing.
It was probably an unfair question, and I wasn't putting the pressure on you to predict the future, but just for somebody who's really deep into it now, and you still have to anticipate. You've got to look ahead too, and so I guess what I'm saying is, okay, if we do go to this, if we were to go to a single payer system, how do you think this would impact this particular model? Would there be a place for it down the road?
I don't know. I mean, I guess they'll start getting reimbursed at Medicare rates if they participate, but then how many patients do they have to take? How many do they have to see?
Well, that's put on. Listen, I guess it was kind of a trick question. I've seen it firsthand. I've had the opportunity to visit Cuba and some other places in Latin America, in Cuba in particular, where the government runs the healthcare system. And what I found is that it's not an efficient system by any means. It's a way to control the healthcare dollars and the system in a sense, but the physicians, it doesn't matter. They get paid $40 a month, whether they see 10 patients a day or 100 patients. So the bottom line is there's no incentive to do better, and everything is basically mandated by the government as to how things are going to be, how they'll proceed. So I just see this, I see what this model offers, one solution to a very complex problem. And I wasn't trying to stump you. I just want to really get your take on this, because this is something where, as we gather in these type of discussions, we kick around ideas, and sometimes something good could come of it.
Well, I believe this, and I've said this, I don't know if I did on Randy's, I don't know. I can't remember what I ate I just can't remember what I drank. What was I drinking? I don't even remember.
Mountain Dew,
but-
I think.
No, it's not coffee. Rhonda goes, you want a coffee mug? I said, well, that's awful kind of you, Rhonda, but I don't drink coffee. She goes, well, just get it and put whatever you want in. So
That's right. We don't care.
it's bourbon. No, I'm kidding.
I was just going to tell you, I've checked it out and it will hold bourbon. I promise you. If you put bourbon in here,
And if it were,
it'll
it
work.
doesn't make
So-
you a bad person.
But here, I mean, and I don't want to go off on a tangent, but what I want to say is there's two things. One, if you were to poll our clients, and I may be getting out over my skis here, but if you were to poll them and ask them how many, and I mean the employees that have the coverage we built with our clients, that their health coverage, if they would want single payer. And I think most of them would say no. And Dr. Bell, the reason is they have no barriers to care. We removed all barriers to care. We want them to take, the insurance companies have raised deductibles and out of pockets, and these dumb brokers out there that just sell insurance. By the way, a broker is someone that makes you broker. Okay. That's the definition of a broker. So when you hire one as an employer, they make you broker. And that's true because your healthcare costs keep going up. You need an advisor. But anyway, thank you. Thanks for laughing. Anyway, it's a true statement, though. It's really not funny. But the bottom line is we've become functionally uninsured as a country. These employers, this group I'm dealing with in Florida, this other hotel company, their deductibles are $3,000. Their average employee probably doesn't make 30 grand a year. At $3,000, they're bankrupt.
Yeah.
So they're scared to death to use their health plan because they don't have $500 in their checking account. So if you ask our clients if they want single payer, I believe they'd say no because they got an unbelievable health plan, and we've done it and we saved millions doing it. So what I'm trying to get at is you have to get rid of all these middlemen.
Right.
When you get rid of the middleman, you can get the doctors back taking care of the members like we're doing. They have an active role. They don't have, and we'll even waive pre-search, probably not for Dr. Bell, but we would for Dr. Cook, but probably not Dr. Bell, but we would waive pre-search for certain physicians or practices so they don't have to spend all that time fighting with a bunch of fools that don't know anything about medicine saying, we don't think this medically necessary. You know, we have that solved in some of ours, so we make the life easier for physicians, but we are able to bring it back with a local care team, the doctor, the pharmacist, get the community pharmacist back involved. Pharmacists, I mean, try to name a pharmacist in your community. I bet you can't. You can't even name one now.
No, well, the other thing you got going, we talk about middle management in the hospitals. Randy got the numbers. It was 1990 hospital like where Dael is might have had 100 administrators. I guarantee you right now it's got 800 to 1,000.
3,200.
And they're all making six figures. And what the hell are they doing?
3,200% increase since 1970.
Go look at UPMC. Go look at how many people make over $1 million in that hospital system in Pittsburgh. Yes, I mean, that's no, but, and here's the other thing. You guys need to be running hospitals. They need the doctors to run the hospitals because y'all understand healthcare. When you look at all the ACOs, whether you're a fan of them or not, I can show that the average beneficiary in ACO a year or two ago saved $68 per year, where our average beneficiary saves almost $3,000 a year. So whatever about ACOs, but the ACOs that are run by doctors are very successful. The ones run by hospitals aren't. So y'all already, I'm preaching to the choir here, but to take it back, you got to be able to start this at a grassroots level. We were in Austin. One of the we'll leave the congressman's name off. He was there and he goes, you know, for 244 years, Congress hasn't really done a lot. So boy, he opened the door for me and I got fired up and started pounding the table. I'm not kidding. I think everybody thought I was going to be carried out of there. But my comment to him was, you said it yourself, 244 years, you've done nothing. So here's what we're going to do. You want to talk about how to fix healthcare? We're not geniuses, but we've done some pretty neat things. Go talk to our clients. We know how to do it. You guys are prey to all the lobbyists and the special interest group, healthcare. I mean, this is the fight, guys, and y'all know this probably, but the healthcare industry spends more in lobbying than defense, aerospace, and oil and gas combined. you're not going to win. So you guys hang out in the ocean, and we'll boil the creeks and the rivers and the lakes, and we'll meet you somewhere in the ocean. But we got to change it employer by employer. So Dr. Bell, you want to stop this train? That's how it has to happen. And you get these employers coming together. The employers need to be the ones calling on the hospitals. You don't need an insurance coming negotiating with you. They don't know. They're terrible at negotiating. Let the employers go to the hospital and say, hey, we're looking at you, HCA. We're looking at you, CHS. We're looking at you, Tenet. What kind of deal are you going to give for us? Where's the insurance coming? No, we want to talk to you. What are you going to do for us?
So
they don't want to pay the insurance companies any more than all of us do. They'd love to be rid of them, but they got to be careful because those processors give them all their patients. We've got to change that.
So what I just heard, one of the things, one of the points that it does, and one of the points that I just picked up there, 244 years of Congress being involved, what has really changed? And you know, but this issue of healthcare or healthcare related issues are always at the front of every election cycle. Yet nothing ever changes or nothing really happens. Only it seems to have gone downhill. So what I'm hearing is that it's ultimately going to be up to us as the physicians to spearhead the change that's needed. But again, I think the disconnect here is, how do we get our voice? How do we get our influence to make this change happen?
You go on appointments with benefit advisors to employers in your community and talk to them about how this can work. You guys have way more credibility than we ever will. But if you go by yourself to these employers to try to work with them directly and avoid the middleman, here's what will happen in that process. They're going to call their broker, and their broker is going to go, you don't want to do that because I can't be on the golf course or the deer stand as quick, and it's going to make me actually work. And so we're not really interested. Click. Then they call you back and say, they don't think it's a good idea, and you're out. You guys have significant contacts in your communities. You know people, you're respected. It needs to be a partnership, and you do really, I think the benefit advisor, and that's probably going to sound self-serving to y'all, is probably one of the most important positions in the country right now to change healthcare, because we are the ones with the ear of the employer. And we can help make that change and make change good for y'all, but we need to all do it together.
So Carl, I want to offer something that I think is eventually going to have to be talked about, and we don't really like to talk about it, but we keep talking about single payer is a bad idea, and you know, so forth and so on, communism and that kind of stuff. But here's the problem. We already have a single payer system. We already have a single payer system. I want everybody to hear that. And the single payer is the patient. Now, the big problem is that when the patient pays, all that money gets spread around amongst politicians and lobbyists and insurance companies and drug companies and all those kind of folks. We need to make sure that what we pay goes to the place where it needs to go. And the CEO of a pharmaceutical company is not the place where it needs to go. I think direct primary care is an excellent start. It is an excellent start. But unfortunately, it will only take care of people who are employed, who have employers that can be influenced. That's still going to overlook the elderly. It's going to overlook the unemployed. It's going to overlook the impoverished. And those people are going to have to be addressed as well. And I don't want to cast aspersions on direct primary care. It is a really great place to start. It is a great place to learn what happens when you remove the barriers between the patient or the potential patient and the provider. And direct primary care illustrates that beautifully. But unless we face the fact that there is an enormous population that has to be served as well, I promise you we're going to get absolutely nowhere, and we can't let the politicians handle it. It will never. Look how well it's worked up to this point.
Amen. Amen, brother.
Can I add to that?
I hoped you would.
Well, first of all, you said it brilliantly. I also want to say there's a few ways to take this on a tangent, which is what happens in doctors' lounges.
That's it.
Yeah, don't let me in your
But
lounge again.
to add to what Randy just said, my entire career, we've had a shortage of primary care physicians. And it's actually getting worse. And we now know some very good data about how you keep costs down and quality up. We know the ratio of primary care to specialty. It's 50-50. 50% primary care, 50% specialty care in any community. We know that from lots of great data that came out of Dartmouth. We have not achieved that. We're at best about 30% primary care and 70% specialists. And we know that the more primary care you have in a community, the better the quality, the lower the costs. We don't have enough primary care there's a lot of reasons for that, a lot of reasons why people don't go into it. Some of it is because, as Carl probably will tell us, some of our med students go see they rotate with burnt out family docs. And they're like, I'm not doing that. I'm overwhelmed. And, I can't take care of 4,000 patients. So the other issue is, let's just say this whole country adopts a direct primary care model. We don't have enough. We don't have enough primary care docs. We don't have enough primary care docs to take 4,000 patients on their panel.
But Dael, don't you think that's an issue going forward in that 60 to 70% of our undergraduates and graduate school students now are women, for one. So not just cast aspersions, but they have families and things like that. I can tell you for a fact on the medical education side of the subspecialty of what I did, cardiothoracic surgery, the quality and the number of applicants is dropping out of the floor because they don't want to do an extra 7 years postgraduate. They have no interest in the lifestyle. And so the caliber that are being trained is lower. So you're going to say, if you need that, you better go to Cleveland Clinic because I don't want to stay in my hometown. But my point to that whole statement was, I don't know what the solution is going forward in the next decade, because I don't, these young, you're on the educational front. It seems to me the young people coming out, first and foremost, they want quality of life. Second is income's way down. They know they're going to make a decent income, so they're not worried about it. They want quality of life and experience with their family and that. And if you tell them, well, you're going to be on call every third night, and they're going, I'm not doing that. So they pick radiology, or they pick somewhere with defined hours, emergency room radiology. In our town, I feel like a lot of them pick dermatology. Don't get me. I'm sorry, dermatologist, but that's just how I feel. So anyways, I don't know. Do you have an idea what that solution would be to fulfill those, or how do we do that?
Well, I'm kind of like answer like Carl just did. I don't have a crystal ball about that. I do know that there are some people who say that there's a lot of things that have been tried, like loan forgiveness programs, and states who are trying to recruit, especially primary care docs, into rural areas. They'll do loan forgiveness. That's one of the ways to do that. Some people are advocating, this sounds a lot like one of our previous presidential candidates, advocate that, like in some other countries, the medical school is paid for by not the student, but by the government. So you get high quality people, and it's just paid for. So you're not incentivized by the income that you're going to get to be able to pay off your loans. That's one of the thoughts.
Yeah,
since I have the floor, I want to change the subject just slightly. But we could follow up on this. And the slight thing is we really ought to have a conversation about what are the goals of health in this country? Because the bigger issue, we're talking access, we're talking lifestyle, we're talking burnout, we're talking all that, but what are the goals of health? So earlier there's a dissing of a single payer system. If you look at the overall health of countries, you probably all know this, we're 39th. We're the worst in developed countries. We're the richest country that has the least amount of health by all the accepted measures of looking at health. And we do know that the ones that are up 1 through 10 have some sort of a system where everybody is covered. It's not all single payer. Like Germany is one of them. Now, I
Mm-hmm.
can't describe Germany's system, but they enjoy very good health there. And there's a lot of reasons for that.
Beer.
You know, Dale, you just opened up a whole
I know that.
important topic.
I know I did.
I'm going to try and kind of give you my little version of this from my perspective. And this is in the course of my career, which is 26 years. And I think really the key question is what, are we talking about healthcare? Are we talking about healthcare system or the overall health of our people? So back in 1996, I'm in my first year of training, VA in Philadelphia. We had 16 million people with diabetes in our country. We had in the wound care world, we had about 300 to 500 products. We had no wound vacs. We had no endovascular procedures, no cellular tissue products, on and on and on. And so here we are in 2021, we're up to 34.2 million people with diabetes. Our amputation rates have gone up since 2009. And so I say, despite all these advances in healthcare technologies and our know-how, we're failing, and we're failing miserably. And I don't know how do we solve this other than changing people's behaviors on the front end and driving this into a preventative type of model. And can we figure out a way to incentivize people beyond scaring them, scared straight? Because it's a terrible thing what I'm witnessing, and I'm so frustrated now because I feel like I've failed. I feel like my contributions have been, for naught almost. Anyway, I just wanted to throw that out there because I think, Dale, you posed a really important, bigger question of all this. It's, paying is one thing, and but here we have a system. Do we blame the system, or is it the health of our people that is really, this is the real problem here?
I'm not you guys, and that's obvious. And I like Dale. I feel what Dr. Waxman does. He hangs out over there, and he either's a pretty good listener or a pretty good faker. And then he throws out these bombs like this now that set the whole thing off. So that's pretty crafty, Dr. Waxman. What I would, well, I agree with everything he says, what Dr. Waxman says, and I hear you too, Dr. Bell. So, I mean, again, if you, and you really want to get back to it too, there's, I think, 170 million Americans that get their insurance from their employer. The employers, I could very well argue, put myself out of a job. Why are they in the health insurance business? And, it was the World War II wage freeze is when healthcare came out and they started paying for it and got to write it off as a tax deduction. But should they be? So when you look at that, you got the Medicare, Medicaid, you got all the Medicaid patients, to your point. You have a lot of uneducated, socioeconomic disadvantaged people that are, obviously ridden with chronic diseases because they've never gone to doctors. And if they do, by the time they get there, they're in such bad shape. So I don't know how you fix that. All I can speak to is looking at it from an employer group. So I will give you all a few statistics. So if I was to take on Rhonda's, company with 300 employees, and that how many you got, Rhonda?
Yeah, about that.
Why aren't we talking? Why haven't you hired us yet? I don't get it. Okay, because you heard the podcast. That's probably all right. But here's what I would say: 10%, to Dr. Bell's point, are diabetics. 10%. Okay. So what do diabetics do? What have we done as a country? They don't get their test strips. They don't take their insulin regularly. They don't do a lot of things. So what do they end up happening to them? They become an ER admit, and they become an inpatient admission. And I don't think I need to tell y'all anything more about how much that costs. And if you hadn't seen, the average COVID patient today is ringing the register at a tune of $317,000 to these hospitals. $317,000, the average COVID patient in our country. All right, so you know where I'm going. So as an employer, I got to keep them out of the hospital. So what we would do is to your Dr. Bell, you want to change behavior, Dr. Waxman, you talk about behavior. If the employee will meet with a community pharmacist for 15 minutes a month, then the pharmacist can synchronize all their meds and their test strips for free. And that member now can take care of themselves and they're already a diabetic, so at least accommodate it and deal with it. But now you made it affordable. Y'all have hit on the socioeconomics of this country is the problem. Randy, you talked about Dr. Cook, sorry. You talked about all these people, how are we going to take care of the poor people? So that's one way you can fix that and break the barriers to care. And if they don't go to the community pharmacist or the doctor, whoever you want to put it to, but the pharmacist is the one giving the meds out, then they pay full price for what they have. When you build plans with dollar incentives, I'm telling you, the people follow the money. They just got a raise in that program that if they were paying for their meds, they were having to pay out of their pocket. So I don't know if that helps, Dr. Bell, with what you said, but I'm just giving you examples of what can be done on this side. And the problem is y'all side doesn't understand our side. And that's the biggest disconnect, in my opinion, is you think that people like me, at least they try to dress nice or look good or whatever, but all they're doing is selling insurance. That's not what we do. We build plans that benefit members, benefit doctors, pay you better than the BUCAs. That's Blue Cross, United, Cigna, and Humana, in case y'all don't know what that stands for. That's the BUCAs. We want to pay the doctors better than what the BUCAs pay them. The doctors are the most important person in the system, and the patient is way out here on the periphery. We got to bring that patient back in, but you have to build plans that are patient-centric. And right now, the plans aren't patient-centric. So
Carl,
people aren't going to take care of themselves.
You are right on exactly what I tried to not so eloquently say before. And
well, you did it in 2 seconds, and it took me 10.
Well, I think the beginning of the solution is that we start taking insurance companies out of it. First of all, I think it's stupid to call them insurance companies. They're not insuring anything. Insurance is something that you purchase to protect you against a financial disaster in the face of some catastrophe. Well, everybody gets sick, and everybody needs to go to a doctor, and everybody needs to have advice and guidance on how to stay healthy. And what excites me about direct primary care is that it is the first inkling of any possibility that I have seen in my career, which dates back almost half a century. It's the first inkling that we might actually be able to get insurance companies to just not be interested in healthcare anymore. And if we can do that, maybe we can start thinking about diverting the enormous sums that go to places where they are not needed to actually help those people who are not employed, either because they're old or disabled or unemployed.
Thank you so much for joining us for this discussion today. If you'd like to learn more about our guest, head on over to our Patreon page, where you can access exclusive content, including the full segment of our show. Never want to miss an Inside the Doctor's Lounge clip? Be sure to click the subscribe button to our MD Coaches YouTube channel. As always, we appreciate suggestions for future show topics. Let us know what you're thinking in the comments below. And finally, special thanks to Ryan Jones, who created and performs our theme music for the show.